Okay, let me go to the next speaker. All right. Our last speaker is Dr. Norah Terrault, who is also well known to this group. She is professor of medicine and chief of the gastrointestinal and liver disease division of the University of Southern California Keck School of Medicine. She has also participated in many of NIDDK's clinical research networks, including the HBRN, and is now the chair and principal investigator in our newly initiated network called the Liver Cirrhosis Network. She is also currently the president of the ASLD, so she's a very busy person, and we are indeed pleased to have her present today. She will give an overview of the outcome of results of the HBRN's treatment of chronic hepatitis B. Norah.
You're on mute, Norah.
There we go. Thanks, everyone. And Jay, thank you very much for the kind introduction. I'm very excited to really present these data to you. The key publication from our randomized control trial was very recently published, but I'm going to do a bit of a deeper dive into some of the areas today, really in the context of focusing on this issue of increasing hepatitis B surface antigen loss or achievement of functional cure. Is there a way for me to turn off the, are you all seeing the caption?
Yes.
Does anyone know how to turn that off? I'm happy to do it, but it may be distracting to you all.
You can go to caption settings on your Zoom if you can find that and turn it off yourself.
1 second. Let me do that.
I just tried to as well.
Okay.
It's closed caption.
I thought it was very progressive of you.
Well, I'm feeling like it might be distracting. So do I go, is it under preferences? Does it? I've never actually had it on, so I'm kind of like surprised.
Get a slideshow.
Okay.
Up there.
Okay.
Unclick that, try that.
Okay. Let's try again. All right, these are my disclosures, and that looks more promising. Thanks. All right, so the study design. I'll just say that our primary aim of the study was to evaluate the safety and efficacy of 192 weeks of tenofovir DF alone in combination with 24 weeks of pegidifferon alpha-2A, and then to use a protocolized treatment withdrawal. And our target population was immune active chronic hepatitis B. So going from left to right, you can see there was a 1-to-1 randomization of TDF for 192 weeks or 4 years, or TDF with 24 weeks of pegidifferon alpha-2A for the first 24 weeks. At week 192, individuals who were eligible for withdrawal of TDF were then withdrawn. The eligibility criteria in terms of withdrawal included having an HBV DNA level less than 1,000 for the prior 24 weeks, an absence of cirrhosis, and then through 2 safety amendments, we also ultimately required all patients to be e antigen negative and anti-HBe positive. If individuals didn't meet the withdrawal criteria during the withdrawal phase, they continued on TDF. And then the patients were followed up to week 240. And at that point, the end of study assessments were made. And our primary outcome was surface antigen loss, and I'll focus primarily on that outcome. But we also had many secondary outcomes, including e antigen loss and a profile consistent with inactive chronic hepatitis B, as well as safety. The key inclusion criteria for the study are very typical for an immune active population. We included both e antigen positive and negative. We stratified based on e antigen status at entry. We also stratified on genotype, A versus non-A, and presence or absence of cirrhosis. You can see that they had to be on no prior antiviral therapy for the prior 24 weeks. We required an ALT level above 1.5 times upper limit of normal. HBV DNA levels greater than 1,000 and absence of co-infection. We did have liver biopsies in all patients coming into study, and they had to have a biopsy that showed an HAI of at least 3 or a fibrosis score of 1. And of course, because we were having peg interferon as one of the treatment arms and absence of contraindications to peg interferon. Now, shown on the right is just specific aspects around the withdrawal phase. I mentioned that it was a protocolized withdrawal. So we had very specific rules around how we monitored for ALT flares and when we intervened with retreatment. And we also had a protocol in which the ALT level led to differences in terms of the frequency of monitoring, again, maximizing the safety in terms of how we did withdrawal. And retreatment was indicated for those with severe or prolonged ALT flares. So you can see the retreatment criteria shown on the far right include any clinical decompensation, anyone with an elevated total bilirubin of 3 or higher, or direct of 1 or higher. And then for most patients, it came down to having kind of persistent elevation of ALT and HBV DNA. We required the HBV DNA to be greater than 10,000, and then either an ALT that was greater than 1,000 for a week, greater than 300 or 200 for males, females for greater than or equal to 4 weeks, or a level of greater than or equal to 150 for more than 12 weeks. Those would lead to retreatment. So this is the study flow, and it's a busy slide, and I'm going to highlight several aspects. So we screened 181 individuals, 102 were enrolled, 102 in the TDF group, and 99 in the combination group. We had a few dropouts before week 192, but overall completion of the study was very high. At week 192 in the tenofovir group, 96 patients were evaluated for withdrawal and 51 met criteria for withdrawal. Of those 51 that were withdrawn in the TDF group, 5 were restarted due to this protocol change. I mentioned that we added in the requirement for being e antigen negative and having anti-HBe. That was the result of our first 2 patients who were e antigen positive having quite significant and severe flares. So we changed the protocol. So we had 5 patients who restarted due to that protocol change here, leaving 46 patients in the TDF group who were withdrawn. And during the withdrawal phase, 7 of those individuals met criteria for retreatment. In the combination group, 92 patients were evaluated for withdrawal, of which 60 met criteria for withdrawal. Of those, 4 also were restarted due to the protocol change, leaving 56 patients who were withdrawn. And of those, 5 required restart during the follow-up period from week 192 to week 240. So I'll be sharing results at 240, recognizing that when we look at 240, it's a combination of patients who were withdrawn and patients who are continued on treatment, depending on whether they met criteria. So what about the patient characteristics at baseline? They're shown here. They're very well matched. About 30 to 40% were female. There were 80% or so that were of Asian American race. Mean age was 41, 7% had cirrhosis. The genotype distribution is shown here, and I highlight that we differentiate between A1 and A2 here. Remember that we stratify based on A, but the A2 becomes relevant when we talk at the results. But you can see because we had a population of predominantly Asian Americans that genotypes B and C do predominate in the study. About half of the patients were e antigen positive. The mean HBV DNA levels at treatment start were around 6.5 log. ALT levels, you can see, were approximately 2 to 3-fold upper limits of normal, and the quant surface antigen about 3 to 3.5 log. So here's the main result, which is our loss of surface antigen. And I'm showing here at the top the intent to treat analysis showing week 192 and 240. And then the graphic shows the cumulative incidence of surface antigen loss by treatment group. And a highlight on the graphic when peg interferon was stopped, which was actually at week 24, and the TDF when it was stopped at 192 and those that were eligible. What you can see is at week 24, approximately 5% of patients had achieved surface antigen loss with no difference between the treatment arms. However, how they came to lose surface antigen does appear to be different. You can see that in the tenofovir group, that most of the loss of surface antigen occurred during the withdrawal phase. In contrast, we see more of the S antigen loss occurring in the combination group earlier in treatment. And indeed, during the withdrawal phase, we didn't see any additional S antigen loss in the combination arm. This is a table that just depicts the characteristics of these patients, the 9 patients who lost surface antigen. And I just want to highlight a few things. The first, if we look at the race, you'll see that we had 2 individuals who are of Asian American race. we have kind of represent the whole spectrum here, but really a predominance of white, given how many individuals of Caucasian race were in the study and how many are represented here. You can see the majority were E antigen positive at treatment onset. Indeed, 8 out of the 9 who lost S antigen were in the E antigen positive group. And then a very striking association with genotype, subgenotype. And you can see that of those that lost surface antigen, 7 out of the 9 had subgenotype A2. Now, finally, at the very end, you'll see that another differentiating feature, again highlighted by the cumulative curves of surface antigen loss, is in the TDF group, that most of those losses occurred off treatment in the period between week 192 and 240, and in the combination group predominantly on treatment. Just one more kind of key slide regarding the subgenotype. So here I'm presenting it in a slightly different way. Here what we're looking at is among those with a specific genotype, what proportion of them lost surface antigen. And you can see that among those that are genotype A2, subtype A2, that 60% of those patients, regardless of treatment group, lost S antigen in the course of this study. So a very striking association that we found in our study between subgenotype A2 and make the distinction from A1, where here we see that none of those individuals lost surface antigen. The other thing to note in this figure is of the very low rate across other genotypes, but of those that have genotype B and C who lost surface antigen, that those only occurred in patients who received combination therapy. Moving on to other aspects of what factors were associated with S antigen loss. Well, remember that the number of S antigen losses are quite low, so we can't do a multivariate analysis to look at sort of things that predict S antigen loss. Rather, what we're presenting here is just by different subgroups, what are the incidence rates or the proportions in which they received that achieved S antigen loss. So not too many surprises here, but just to give you a context of the magnitude of difference. So you can see Asian versus non-Asian, 1.4%. Sorry, that's flipped. Non-Asian was 1.4%, 20%. Sorry, that's not flipped. Asians were 1.4%, our non-Asians were 20.6%, where I highlighted that the whites and blacks were the individuals who had S antigen loss. Again, the E antigen positive was a relevant factor, A2. And then we see that high viral load and high S antigen levels at baseline were associated with higher rates of S antigen loss. Our interpretation of those data is it's really reflective of E antigen status. So it sort of goes in hand with our association of E antigen being positive patients having higher rates of S antigen loss. Now this shows this E antigen versus positive versus negative. And here what we're looking at is, rather than looking at loss, which we have very few of, here what we're focused on is the decline in surface antigen over time. So there is a greater decline in terms of log IU per ml in the E antigen positive group compared to the E antigen negative group over the course of the study. And moreover, there's that earlier decline that we see in patients who are E antigen positive, and more so in individuals who are treated with a combination therapy. Now, I did mention we also had several secondary outcomes. I did want to focus the talk here on S antigen, but just to make the point that E antigen loss was seen among the 103 who were E antigen positive at a higher rate in our combination group compared to the TDF alone. And the other one aspect of secondary outcomes that I wanted to emphasize is what we would call inactive chronic hepatitis B at the end of treatment at week 240. And this is, so I highlight here, these would be described as somebody who has an HBV DNA level under 1,000, a normal ALT, and is E antigen negative. And I show the results. They're not statistically significant between the two treatment groups, although there is a numerical difference. You can see that in the combination group that was seen in 33% of patients, TDF alone 18% of patients. And then the final bar at the very bottom is that same inactive chronic hepatitis B, but this is only among patients who were withdrawn from treatment. So this is an off-treatment response. And you can see that approximately 32 and 25% of patients in the two arms achieved that endpoint. Now, just one slide on safety. I think it's really important, the withdrawal of TDF is recognized to be something that can be potentially of risk. First of all, just to highlight, we had AEs in 280 total of 201 participants, but only 3% of them were serious adverse events. The first thing is that the vast majority of them were unrelated to treatment. But of those that I want to emphasize, the first is that we had 2 life-threatening and definitely related complications in the group that received TDF alone. Both of these patients developed this life-threatening hepatic decompensation during the withdrawal of the TDF. And indeed, these were the 2 patients who were e-antigen positive, because our initial criteria allowed us to withdraw those patients if they otherwise met the HBV, DNA, and ALT criteria. But of course, when we had these 2 events, this led to the amendment of our protocol so that no longer were e-antigen positive patients withdrawn. And then the other thing to note is that in the PEG interferon arm, we did also have 3 serious probable and 3 definitely related adverse events. These are, I think, well recognized to be potentially interferon associated, but just highlights the challenges in potentially using PEG interferon, but overall rates were low. So to summarize the first part, because I'm going to now do a deeper dive into ALT flares, but just in terms of the main messages from our randomized trial, overall rates of S antigen loss were low, 5%, and not significantly enhanced by the combination of PEG interferon for 24 weeks with this longer term TDF following and a protocolized withdrawal. However, we do show that S antigen loss timing is different when a patient receives PEG interferon as part of their initial treatment. The withdrawal of TDF after 4 years was safely achieved, particularly in an amended protocol in which they required patients to be e-antigen negative and anti-HBe positive. And we feel that that's a very important aspect in terms of a criteria for withdrawal, as well, of course, as the absence of cirrhosis. S antigen loss strongly influenced by subgenotype, and the association with A2 is one of the very novel aspects of this study. But we also highlight the importance of e-antigen status, where we had well-characterized e-antigen positive negative groups to compare and show that e-antigen positive status at onset of treatment is an important predictor of S antigen loss. And I think this is something that maybe warrants greater consideration in new therapeutic trials. And then finally, the one other thing to note is in this very well protocolized approach, that the rate of S antigen loss in individuals who started out e-antigen negative was extremely low, only about 1%, which highlights that this is a group in which I think there's still a huge need for new therapeutic approaches. Now, I'm going to spend a few minutes just to delve into ALT flares, because these were very carefully collected in the study. All of our ALT flares were adjudicated, and we had in the trial itself, flares were characterized in a specific way based on an ALT level greater than or equal to 300 and 200 for males and females. But the data I'm going to share with you are actually from post-hoc analyses in which we use a more refined approach to talking about ALT flares. And for these analyses, it required that the ALT be greater than 2 times the baseline, or in the case of withdrawal flares, 2 times greater than the ALT at the time of treatment withdrawal. And then they had to also meet the criteria for a flare intensity, which we characterize as mild, moderate, or severe. So what I'd like to first share with you is data that has been presented by Bob Perillo, not yet published, in which we've focused on ALT flares during treatment. And what you can see here is that we had 46 participants who had a total of 50 on-treatment flares. Shown in the figure is the proportion that had flares. You can see that there were ALT flares both in patients who received TDF alone, as well as in those that received combination therapy, although they were more frequent in the group that received combination therapy. Not shown here, but what I can share with you is that they were also more common in patients who are e-antigen positive. And when we looked at the relationship between having an on-treatment ALT flare and having S antigen decline, because in this case, what you can see is the flare, patients who had flares had a much greater likelihood of being able to achieve a decline in surface antigen to less than 100. That's shown on the left. And shown on the right is that the decline in quantitative surface antigen is indeed related to the severity of the flare. And you can see going from top to bottom, no, mild, moderate, and severe flare, that we also see that moderate and severe flares during treatment were associated with a greater likelihood of S antigen decline, and that was specifically seen in the combination group. So this ALT flares is a marker for this effect on S antigen decline. And in the study, which looked at patients that then got to the end of their treatment at week 192, and how many of them had a surface antigen level less than 100, you can see that the same factors that we sort of spoke about earlier are coming out. There is, in this analysis in which we use surface antigen that was less than 100 as the outcome, that there is a difference between the treatment groups. Genotype A comes out being important. A baseline quantitative surface antigen is also important, but really what I want to emphasize is, again, that the flare group is a group that had a higher likelihood of achieving that outcome. Now I'm going to flip from the ALT flares on treatment to now the ALT flares that occurred during treatment withdrawal. And I think one of the key questions that the network wanted to answer is a post-withdrawal flare beneficial? That has been in the literature that this is something that is necessary in order to get S antigen loss or S antigen decline. So for this analysis, this is just to show that it's a subgroup. You can see that the ones withdrawn were 43 in the tenofovir alone and 49 in the combo group. And this is just to show you their characteristics at the time of withdrawal. They're quite well balanced, with the exception be that there's a greater proportion in the combination group had a quantitative surface antigen level less than 100 at the time of treatment withdrawal. But when we look at, again, flares here and their relationship to various characteristics, the first thing is to say that the rate of flares in those withdrawn didn't differ by their treatment group. That's shown on the left. And shown on the right is, did the likelihood of flare vary by whether they're e antigen positive versus negative? And the answer is that yes, ALT flares after TDF withdrawal were more frequent, and they tended to occur earlier in the e antigen negative patients. But interestingly, retreatment was actually required more often in our e antigen positive patients. And then finally, does that flare lead to S antigen decline? Is it a benefit in that way? Do we see that linkage? And what this shows us here, focused on the grade 3 flares of greater than 5 times upper limit of normal or higher, is that they're not. And that indeed the ALT flares did not associate with the decline in surface antigen or S antigen loss in follow-up. And indeed, the S antigen decline was greater in participations without a grade 3 ALT flare. And when we did an analysis looking at the predictors of ALT flares, we indeed showed that ALT flares are more common early after TDF withdrawal. They're more common in older participants, and they're more likely in individuals who have a pre-treatment high HBV DNA level. But probably the most important finding in our study was that these grade 3 flares could be predicted by an HBV DNA level on the visit prior. So if their HBV DNA level was 4 logs on the prior visit, they had a much greater likelihood of ALT flares of grade 3 or higher, suggesting that we can predict these severe flares, and that these flares in turn are not related to surface antigen loss. So one final slide. I know that this is a lot of data, but just to leave you with, well, what about the idea that ALT flares can be beneficial in terms of achieving inactive chronic hepatitis B? So now looking at that as an endpoint. Inactive in this graphic is shown by the blue, and then shown here are flare versus no flare groups using grade 3, 5 times or more times upper limit of normal. And it shows that, again, the ALTF flares are associated with, the ALT flares group, which is shown here, is much more likely to have active chronic hepatitis B at the end of the study. So again, not a benefit, but actually potentially telling us of risk. So just to conclude, this is my last slide in terms of summarizing the flare data, is that overall in the study, we had flares throughout the study in about 1/4 to 1/3 of the patients, with no difference between the treatment groups overall. But there was a higher proportion early in treatment with the PEG interferon tenofovir group, higher proportion later in TDF alone. We showed that ALT flares on treatment do predict a decline in quantitative surface antigen, but we showed that ALT flares during withdrawal do not. And moreover, that a HBV DNA level of greater than 4 log on a prior visit predicted a flare that could be of severe nature. So with that, I'll close. And again, I want to acknowledge really this collaborative effort, and in particular, want to thank my colleagues for all of their efforts in executing this trial. Thank you.
Well, thank you, Nora, for that presentation of very complex data. Let me say something about it. I believe what the study showed is we're dealing with two diseases, the E-positive disease and E-negative disease. In E-negative disease, the addition of interferon didn't do anything. There's no increased loss of S. And by the end of treatment, there was equal suppression of HBV DNA and ALT. It did seem to have an effect in E-antigen positive patients. You showed the close association of A2 with response. It's important to point out it was only A2 and E-positive patients. If you were A2 and E-negative, nobody cleared S. If you were A2 and E-positive, 100% of patients who got PEG interferon cleared E and S. If you were E-positive and received tenofovir alone, there's small numbers, there are only 6 patients, but only of those, only 4 lost surface antigen. There were 2 who did not. So I think it's, if as far as PEG interferon is concerned, which is the study was supposed to address, does the addition of PEG interferon add anything to therapy? I think it doesn't if you're E-negative. If you're E-positive, it leads to an earlier loss and more secure loss of both E and surface. In fact, the loss of E with PEG interferon was over 60%, whereas with tenofovir alone, it was 30%. So the addition of PEG interferon does add something, but what the study also shows is that we need another agent to really get a solid 100% loss of E and loss of S. So with that, let's go to the questions. One question is this is going back to the question is, if you lose surface antigen, did anybody rebound and become positive again?
We didn't have any seroreversions for S. So once they acquired surface antigen, we did not see anybody who flip-flopped back.
Even with withdrawal?
Pardon me?
Even with withdrawal?
During withdrawal, we did not see anybody who flipped. I mean, there are some individuals whose surface antigen, we have the levels as well. So you can sort of sometimes see they're right at the threshold. I'm not sure that that's really somebody who's flipped so much as that we have a kind of detection issue. But I think anyone in which we saw surface antigen that was truly not right at the threshold, but was negative, we did not see those individuals flip back during withdrawal.
Right.
Jay, this is Brian, and I'll comment on that too, because we have we're about to submit our paper on HBsAg loss following 1,100 people for 32,000 years of follow-up in Alaska. And I agree with Nora completely. We found that there's a few people that became transiently HBsAg positive after E-loss, but they all can flip back to HBsAg negative. Now, possibly there's more sensitive tests that detect HBsAg than what we have commercially, and I know NIH is working on this, NIDDK. But right now, I'd say I think HBsAg loss, you can be very confident that it does occur. And then the other comment is that it's important to remember that A2 genotype is a European genotype, not the African. That's A1, A3. Interestingly, all the African American persons in the study that had A genotype had A2. And so I think that's an important issue, and that those findings on A2 are very interesting and worthwhile looking at again. We do have some A2 data too.
Right. Now, also the drop in S titer with the flare, I think that's due to clearance of E antigen. When you clear E antigen, the titer of surface antigen drops by about a log. So the flares are mostly E antigen clearance flares. And with that, there's this drop in HBV DNA. So I'm of the belief that a flare is usually bad. But a flare on treatment is not necessarily bad.
No, I think that our
You have to
data-
look at what HBV DNA is doing.
Mhm.
you
Right.
see.
Yeah, but I mean, I think if you're just, I think it's to make that distinction that on treatment, ALT flares are quite different than what we are seeing post in the withdrawal phase.
Right.
And probably our data is, I think, building on data that are suggesting that this concept that an ALT flare is kind of a necessary component of withdrawal in order to get S antigen loss. I think we're adding to that. I think this study very strongly shows that that having flares isn't a requirement to getting S antigen loss. In fact, most of our patients who had S antigen loss and follow-up, it's the continued slow decline of surface antigen. So I think that helps us because in these withdrawal studies, it's always kind of unclear about should you intervene, yes or no. And so I think, having this concept that severe flares for sure are not beneficial. And now we potentially have a way to identify such flares earlier, and maybe that's going to help us to do it in a more safe fashion.
Right.
Oh,
The
Nora and
flares
Jane,
actually occur before the loss of E.
Yeah. Yeah.
And the enzymes are fall to normal by the time the E is lost. We still don't quite understand what it is that's what's happening. But
Jay
that
and Nora,
association with flare and a drop of HBV DNA is
Jay-
favorable, as opposed to withdrawal where the HBV DNA is
Going
rising.
right.
Yeah.
is
Exactly.
there any evidence of mutations in the virus in those people that had flares?
Yeah, we don't have
We
that.
don't have that data. We don't have that data.
It's a
Again,
great
comes back to this issue of the repository of this study will be available eventually.